Welcome to the deep dive. Today, we're cutting into the evidence that is really reshaping modern orthopedic trauma practice.
We are indeed.
We're moving beyond some of the more established protocols and right into that delicate balance between mechanical stability and biological preservation.
It's a critical conversation to be having.
Our focus today is on those key decision points. When does a minimally invasive approach actually give you a truly superior biological outcome? How do we navigate the risk of contamination in open fractures?
And, of course, the role material science is now playing and how we optimize fixation for the best long-term benefit for our patients.
It's a fascinating time for orthopedics, as our techniques, especially things like minimally invasive plate osteosynthesis, MIPO, and advanced digital planning, get more sophisticated. The whole landscape is shifting.
It is, which means we have to be more rigorous than ever. We really need to evaluate precisely when that biological advantage of avoiding a big exposure genuinely outweighs the technical demands and the trade-offs of an indirect reduction.
Absolutely. So our mission for you today is to unpack the granular detail from the very latest comparative studies. We want to give you the data to help you refine your own clinical judgment.
We'll be looking at internal versus external fixation, MIPO's effectiveness in different parts of the body.
And then we'll get to the cutting edge. Things like bioresorbable materials and even AI-driven surgical planning.
Sounds good.
So let's begin with that big trend toward minimal invasiveness. In which part of the body has the evidence been most forceful in, shall we say, challenging the conventional gold standard?
Oh, that would unequivocally be the humeral shaft, without a doubt.
The humerus.
Yes, that's the anatomical location where MIPO has delivered some of the most compelling biological data we have, and it directly challenges what we've always done, open reduction and internal fixation, or ORIF.
Right. For years, ORIF has been the go-to, the gold standard for those diaphyseal humeral fractures that need fixing.
Of course.
And it makes sense because it offers direct visualization of the fracture. You see everything, you can guarantee an excellent anatomical alignment.
The classic approach.
But the recent systematic reviews are making a really powerful case that while MIPO gets you to the same functional result in the end, it offers a far superior biological environment for healing.
That's the crux of it.
So walk us through the evidence base. How robust is this claim?
It's very robust. We're looking at a large systematic review that pooled data from 11 different comparative studies.
Okay.
So a substantial cohort of 582 patients. And the place you have to start this debate is always the functional outcome. Does the patient get better?
The end result.
The end result. And here, the studies confirm equivalence. When you assess them using all the major functional scores for the upper limb UCLA, Mayo Elbow Performance Score, DAGE, DRANCH, ACs, the pooled analysis consistently showed no statistically significant difference.
No difference at all?
None. In the long term, functional recovery between MIPO and ORIFIS is the same.
So, if the patient ends up with the same level of function, the same use of their arm in the long run, why are we having this conversation? Why would we shift practice away from a technique that absolutely guarantees you get that perfect anatomical reduction?
That's the critical question, isn't it?
What is MIPO actually providing that ORIF can't?
The difference is entirely in the journey to get to that union. And that's where MIPO generates this huge, significant biological value. We see three key measurable biological advantages.
Okay, let's break them down. What's the first one?
Firstly, MIPO results in significantly faster union.
Right.
The collective data shows that MIPO shortens the mean union time by about 3.12 weeks compared to ORIF.
3 weeks? That's not a trivial amount of time.
It's not at all. Achieving consolidation nearly a full month sooner is highly significant. And not just statistically, but clinically. It massively impacts a patient's dependence, their return to activity, their quality of life.
That sort of accelerated healing suggests a really dramatic shift in the biology at the fracture site itself. What's the mechanism that's driving that speed advantage?
Well, that mechanism also explains the second critical advantage, which is a significantly lower non-union rate.
Okay, so they're linked.
They're directly linked.
Yeah.
The pooled odds ratio for non-union was a very clear 0.27 in favor of MIPO. Highly significant. This is where the core principle of MIPO, that idea of relative stability through bridge plating, really shines.
Explain that a bit more.
When you perform a conventional ORIF, you have to do an extensive surgical dissection. You're often stripping the periosteum all the way around the bone to get that direct view.
Which devascularizes the fragments.
Exactly. You cause devascularization of the fracture fragments, and you disrupt and physically remove the fracture hematoma. And that hematoma is nature's biological scaffold. It contains all the growth factors, all the progenitor cells you need for healing.
And MIPO leaves it alone.
MIPO preserves that entire crucial biological envelope. By maintaining the hematoma, by preserving the osseous vascularity, the body's natural healing cascade is respected, it's accelerated, and that leads directly to that reduced non-union risk.
So it's the preservation of the biological milieu versus the comprehensive mechanical approach of ORIF.
Precisely.
Let's move on to complications then. Infection is always a major concern in any fixation surgery. Does that reduce soft tissue disruption from MIPO translate into lower infection rates?
Yes, it does.
Yeah.
We see a statistically significant reduced infection rate in the MIPO group.
By how much?
The p-value was 0.03. Now, humeral infection rates are generally quite low anyway, but any reduction is obviously valuable.
And the reason is simply less dissection.
It's directly attributable to it. Less extensive soft tissue damage means less dead space, less tissue devascularization, and as a result, a lower risk of introducing contamination or creating that hypoxic environment where a deep surgical site infection can really take hold.
The biological benefits are stacking up, and they're very clear. But let's talk about the specific iatrogenic risk that, well, it shadows all mid-shaft humeral surgery. The radial nerve.
The radial nerve, of course.
Does MIPO offer genuine protection here? Because that's a huge factor in patient outcome.
It offers substantial protection, and this is perhaps one of the most compelling clinical arguments for its adoption.
What does the data show?
The rate of iatrogenic radial nerve palsy was significantly lower in the MIPO cohort. It stood at only 2% compared to a, frankly, worrying 8.6% in the ORF group.
That's a fourfold difference.
It is. That difference, reflected by an odds ratio of 0.31, is a huge clinical margin. It's a massive risk reduction for the patient.
So why is MIPO structurally protective of the radial nerve? Is it purely because the incisions are smaller, or is there something more to it?
It's a combination of anatomical protection and technical restraint. You see, most MIPO techniques for the humerus use an anterior or an anterolateral approach.
Right.
Now, when you're using that anterior approach, the brachialis muscle acts as this robust protective cushion. It physically interposes itself between the plate, which you're putting on the front of the bone, and the radial nerve, which lies deeper in the posterior compartment as it winds around the shaft.
So it's a natural shield.
It is a brilliant natural shield. And on top of that, the limited nature of the MIPO incision just inherently restricts your field of view and the instruments you can use. This significantly reduces the chance of an accidental iatrogenic injury during that deep dissection, a risk that is magnified in the extensive exposure you need for a traditional ORFO.
So MIPO delivers equivalent function, better healing time, lower non-union, lower infection, and a significantly reduced risk to the radial nerve. That sounds like a fairly decisive argument.
It's a strong case.
Let's look at the operational factors. Does it also provide greater efficiency in the operating theater?
In terms of theater time and blood loss, yes. MIPO, again, performs very well. The comparative data shows a significantly shorter surgical duration. We're talking a mean difference of almost 23 minutes shorter.
23 minutes per case adds up over a list.
It certainly does. And furthermore, intraoperative blood loss was markedly smaller, on average over 193 milliliters less.
Wow.
So it's a faster, cleaner surgery, which is obviously beneficial for the patient, but also for the efficiency of the whole theater schedule.
Now for the big question. We have to address the elephant in the room. The trade-off.
There's always a trade-off.
Because MIPO relies on indirect reduction, anatomical perfection can be, well, a challenge to achieve. What does the evidence say about the risk of malalignment, specifically rotational malalignment, which is the hardest one for a patient to compensate for functionally?
This is the critical vulnerability of MIPO. This is the point that necessitates absolute surgical discipline.
Because you can't see the fracture ends directly.
Exactly. Without direct visualization, getting that perfect alignment relies entirely on your technical skill and meticulous intraoperative fluoroscopic control. And the data reflects this challenge. One study focused specifically on measuring rotational malalignment using the humeral retroversion angle from postoperative CT scans.
And what did it find?
The MIPO group showed significantly higher rotational malalignment, an average of 18.2 degrees with a very wide standard deviation of 15.4 degrees.
18 degrees. That's a lot.
It is. Now contrast that with the ORIF group, which averaged a much tighter 7.4 degrees of malalignment. That difference is highly significant, and it confirms that MIPO carries a substantial inherent risk of clinically significant malrotation.
And how do we define clinically significant?
Usually anything exceeding 15 to 20 degrees. That's the point where it can start to lead to functional deficits, particularly in activities like reaching overhead or even driving a car.
That 18.2-degree mean is problematic. I mean, if the functional scores are ultimately equivalent, perhaps many of the errors fall just below that symptomatic threshold. But relying on that seems risky.
It is risky.
So as professionals, how must we mitigate this specific rotational risk when we're performing MIPO?
Mitigation is absolutely essential, and it requires standardized protocols. There's no room for improvisation here.
So what does that look like in practice?
The surgeon has to employ rigorous, repeatable, intraoperative checks. This means ensuring that your C-arm views are perfectly orthogonal to the bone to prevent any visual distortion.
Right.
And crucially, the external landmarks must be consistent. This means positioning the forearm in a standard position, often full supination, during the final stages of plate fixation. You have to use the elbow and the wrist joint alignment relative to the shoulder as your external guide for rotation.
What about comparing to the other side?
Some surgeons advocate for checking rotation against the contralateral uninjured limb, but even that can be quite challenging to standardize perfectly when the patient is draped.
So we're balancing this huge biological gain against a very defined technical risk.
That's the summary.
The message seems clear. MIPO is biologically superior, but its application requires a real technical mastery of indirect reduction and non-negotiable rotational vigilance to avoid a poor mechanical result that just negates all those biological benefits you work so hard to preserve.
You've put it perfectly.
That sets a very strong benchmark for these minimally invasive techniques. Let's shift our focus now down the limb to open tibial fractures.
Very different challenge.
Absolutely. These are high-energy, high-stakes injuries where contamination and the state of the soft tissues critically complicate the choice between internal fixation and external fixation.
Yes, open tibial fractures represent a significant challenge. They're often the result of road traffic accidents, major trauma. And the fixation strategy here, it's less about biological preservation, because the initial injury has already caused massive biological disruption.
Damage is done.
The damage is done. It's more about damage control, about eradicating contamination and achieving a stable environment for healing and for soft tissue coverage. And for this, the Gustilo-Anderson classification is our indispensable guide.
Right, classifying the severity based on wound size, soft tissue damage, contamination level.
Exactly.
Okay, so we have a prospective comparison between internal fixation, IF, and external fixation, EF, in Gustilo-Anderson types I, II, and III. Over a 12-month follow-up, what were the key findings from that study regarding union time and function?
The study, which involved 40 patients in each arm, provided some very compelling data that, under the appropriate conditions, internal fixation offers measurable advantages.
What was the first one?
The first major finding was a highly significant union advantage for IF.
Okay.
The mean time to union was 19.8 weeks for the internal fixation group, compared to 23.6 weeks for the external fixation group.
So that's almost a 4-week acceleration.
Yes, and that is a substantial difference in the context of a tibial fracture.
Why does internal fixation lead to faster union in an open fracture setting? Even if the wound has been meticulously debrided, you'd think the biology would be compromised.
The mechanism is really about superior mechanical stability and, crucially, earlier functional loading.
Right.
Internal fixation, which in the tibia is typically an intramedullary nail, provides far greater axial and torsional stiffness than most external frame constructs can.
So it's a more robust fixation.
Much more robust, and the superior stability allows for earlier weight-bearing and patient mobilization, which are absolutely crucial biological stimuli for secondary bone healing. Prolonged, rigid external fixation can sometimes delay that hypertrophic callus response you need for consolidation.
And did this mechanical advantage translate into better functional scores for the patients?
It did, yes. Using the Johnner-Roos criteria, which assess things like pain, gait, mobility,
Yeah.
the IF group demonstrated superior overall functional results.
How much better?
They achieved excellent or good outcomes in 80% of cases, which was significantly higher than the 66.7% achieved by the external fixation group. Better stability simply means less secondary displacement and a quicker path through rehabilitation.
This brings us to the core dilemma, doesn't it? We are all trained to fear putting internal fixation, a foreign body, into a contaminated wound.
Absolutely.
The risk of a deep infection is often catastrophic. It can mean long-term antibiotics, multiple surgeries, and potentially even amputation. Yet this study seems to suggest the infection rates were comparable, or perhaps even slightly worse for external fixation. How do we reconcile that paradox?
This is where we need to look closer at the type of infection and the specific morbidity that comes with each method. Let's look at deep infection first, the most serious one.
Yep.
It was actually reported as slightly higher in the EF group, 10% versus 3.3% in IF, though the sample size wasn't big enough to make that specific difference statistically significant.
And superficial infections.
Superficial rates were 20% for EF and 13.3% for IF. But the key takeaway here, the real story, is the specific morbidity of external fixation itself.
You mean beyond the fracture?
Yes, EF avoids placing metal across the primary contamination zone. That's its purpose. But it substitutes that risk for another one, pin tract infection.
Which is incredibly common.
Incredibly. This complication occurred in a highly significant 20% of the EF patients in this study. And while they're often manageable, pin tract infections are a major cause of pain, they require frequent dressing changes, they can lead to a localized osteomyelitis around the pins.
And they can compromise the whole fixation.
They can. They often necessitate early removal or revision of the frame, which just delays the definitive treatment and prolongs the whole process for the patient.
So to summarize, EF carries a low but potentially catastrophic risk of deep infection, while EF carries a near certain high rate risk of significant but non-catastrophic morbidity from pin tract infections.
That's a very good way of putting it. And you also have to add in the higher rates of malunion with EF 13.3% in this study versus 6.7% in IF, and of course the slower union time we already discussed.
So the functional cost of external fixation is borne out in the data.
It is slower healing, higher malunion, chronic pin site issues. So the clinical synthesis, the decision we make, has to be nuanced. It has to be dictated by the Gustilo-Anderson subclassification.
Okay, so how does that classification specifically inform the choice? When must we still rely on external fixation despite these functional downsides?
External fixation remains the non-negotiable standard for Gustilo type 3B and 3C injuries. There's no debate there.
Let's break those down. Why for 8-3B?
For a type 3B, the definition is extensive soft tissue loss that's going to require a free tissue transfer or a flap for coverage. You've often got periscale stripping, massive contamination.
An impossible environment for a nail or plate.
Exactly. Implanting a nail or a plate there, even after the most aggressive debridement, carries an unacceptable risk of a deep-seated infection, especially if that soft tissue coverage is delayed. EF gives you immediate stabilization while permitting totally unrestricted access for the plastic surgeons to do their work.
And for a type 3C?
For a type 3C, where you have an arterial injury that requires vascular repair, EF is typically mandated as part of a damage control orthopedics procedure.
The priority isn't the bone.
The priority is saving the limb. It's about rapid, temporary stabilization to facilitate that life-saving vascular and nerve repair. Definitive fixation is deferred until the limb is stable and the contamination is controlled.
So the study's findings primarily support using internal fixation as the definitive treatment for Gustilo type 1, type 2, and very carefully selected type 3A injuries.
Yes, provided that the initial meticulous surgical debridement has been perfectly executed.
That's the crucial caveat.
It's everything. For those lower-grade injuries, where the soft tissue envelope is viable and the contamination has been effectively managed, the functional gains you get from IF, the speedier union, the superior stability, they outweigh the residual infection risk.
But you have to be ready to change tack.
Always. The surgeon must remain ready to use EF as a critical, temporary measure, a bridge to definitive fixation, understanding that the patient's functional journey will be more protracted and fraught with those frame-related complications. It is the absolute definition of a tailored, risk-adjusted approach.
That detailed discussion on fixation choice leads us seamlessly into our next patient cohort, the elderly fragility fracture patient.
A group where comorbidities and the immediate goal of mobilization dictate absolutely everything.
Let's start with pelvic ring injuries. We're not talking high-energy trauma here, but low-energy falls.
Exactly. Pelvic ring fractures, or PRFs, in the older adult are a distinct entity. They are often low-energy insufficiency fractures from a simple fall from standing height, yet they carry an incredibly high morbidity.
And what's the typical patient profile?
The median age in most studies is around 74, and these patients often present with a host of other health issues, which is reflected by a median Charlson comorbidity score of 4.
So they're quite frail.
Very. And surgical stabilization here isn't primarily about achieving perfect anatomical reduction. It's a quality-of-life intervention. The aim is squarely on achieving rapid analgesia and restoring their pre-injury mobility as quickly as possible.
If the goal is rapid functional recovery rather than perfect anatomy, How effective is the minimally invasive percutaneous approach for these injuries?
The use of minimally invasive percutaneous screws, SI screws, transsacral screws, pubic rami screws, has really become the standard of care for stable and rotationally unstable patterns in this group.
Why is that?
By avoiding large open approaches, we dramatically limit the surgical stress and the blood loss in a patient who is already very fragile. And the success metrics we use, well, they're powerfully patient-centric.
What were the key patient outcomes from the data you've seen?
Firstly, a very high level of patient satisfaction was achieved. Retrospective data reported that a remarkable 98% of patients were pleased with the surgical results.
98%.
And crucially, 91% achieved an acceptable level of post-treatment mobility. They either maintained or returned to their prior functional status. For someone in their 70s with multiple health issues, maintaining their independence is the absolute gold standard outcome.
And how quickly did the procedure deliver on its primary function, which you said was pain relief?
The analgesic effect is immediate and profound, and this is the key that unlocks that rapid return to function.
What do the numbers show?
The mean pain score during mobilization, measured on the numerical rating scale out of 10, dropped significantly. It went from an average of NRS 6 preoperatively, which is significant pain,
Right.
down to just NRS 3 at the time of discharge. That level of pain control is the engine that drives early weight bearing. And this is what facilitates most patients returning to their own home, rather than needing a costly and very deconditioning stay in an extended care facility.
That makes perfect sense. Minimally invasive surgery in this patient group is really a tool for rapid functional restoration. You're maximizing the time they're active and minimizing time spent in theater or confined to a bed.
That's the entire philosophy.
This focus on maximizing mobility and tailoring fixation brings us to a really fascinating and predictive correlation that's been found in proximal femur fractures.
Yes, this is a very interesting area.
Researchers have found a direct link between pre-existing hip osteoarthritis and the actual pattern of the fracture itself. This seems like a profound insight into fracture pathology.
It is indeed. This was a retrospective study. It analyzed 448 patients with proximal femur fragility fractures, and it established a statistically significant and highly predictable correlation between the grade of radiographic hip osteoarthritis.
Using the Kellgren and Lawrence system?
Yes, the KNL classification. A correlation between that and whether the patient suffered an intracapsular, so a femoral neck fracture, or an extracapsular, a petrochanteric, or subtrochanteric fracture.
So, is the relationship direct? Does severe arthritis increase the risk of a neck fracture, or is it the other way around?
It's an inverse relationship.
Yeah.
Higher degrees of radiographic hip OA correlate strongly and significantly with extracapsular fractures. Conversely, patients who have minimal or no radiographic OA are far more likely to sustain the more serious intracapsular fractures.
Can you illustrate the magnitude of that shift using the K and L grading? It sounds quite dramatic.
It's very dramatic. Let's consider the minimal end of the spectrum first. Patients classified with KNL grade 1 OA, so those with just minimal osteophytes but no significant joint space narrowing.
Okay.
They suffered intracapsular fractures in a striking 85.6% of cases. Only 14.4% were extracapsular. The femoral neck is clearly the weakest point in that group.
And at the other end, the severe arthritis group.
Now you look at the severe end. Patients with KNL grade 4 OA, those with significant joint space narrowing, large osteophytes, subchondral sclerosis.
Classic worn-out hip.
The classic worn-out hip. They suffered extracapsular fractures in a staggering 81.5% of cases. The occurrence of an intracapsular fracture in that group drops to a mere 18.5%.
Wow.
The failure pattern dramatically shifts away from the femoral neck as the OA severity increases.
This is more than just a correlation. This suggests there's a protective mechanism driven by the underlying pathology itself. What are the proposed biomechanical or physiological hypotheses that could explain why advanced OA seems to protect the femoral neck?
There are two dominant and probably interrelated hypotheses. The first one is all about bone mineral density, or BMD.
Right.
It's well established that patients with advanced hip OA often exhibit increased BMD, particularly in the femoral neck region, when you compare them to age-matched controls who don't have OA.
So the bone is denser.
It is. This localized densification is likely a response to the chronic altered mechanical loading and the increased stress that's associated with the arthritic process. So this denser, stronger bone in the neck is simply more resistant to failure during a low-energy fall. The second is more biomechanical, and it relates to a restricted range of motion, or ROM.
It's a stiffness.
The stiffness. Osteoarthritic hips lose their range of motion. Studies suggest that hips with greater ROM are more susceptible to the shear forces that cause those intercapsular fractures, whereas hips with significantly restricted ROM, which is typical of a grade 4 OA, tend to shift the stress failure vector laterally, out to the weaker, less dense trochanteric region upon impact.
So it fails somewhere else.
The stiffness just changes how the energy from the fall is absorbed and transmitted through the bone, resulting in an extracapsular fracture instead.
This predictive insight has massive clinical implications, not just for confirming a diagnosis in, say, an occult fracture, but for preoperative planning.
Indeed. If you have a patient who presents with traumatic hip pain and on their x-ray you see clear evidence of K&L grade 3 or 4 OA, the predictive capacity leans very strongly toward it being an extracapsular injury. That guides your need for advanced imaging and your management plan.
And beyond diagnosis.
Well, it impacts the treatment pathway itself. Extracapsular fractures are typically treated with internal fixation, like an intramedullary nail, and that procedure generally involves lower immediate postoperative mortality, less blood loss, and fewer acute complications than managing an unstable intercapsular fracture.
Which often requires an arthroplasty, a joint replacement.
Exactly, a hemi or total arthroplasty.
Well,
Therefore, by shifting the failure pattern, advanced OA indirectly moves the patient into a lower-risk fracture management category.
that is truly fascinating. A chronic pathology that inadvertently offers a protective effect against the highest risk fracture pattern.
It is.
But this leads directly to a provocative question you often raise. How does coexisting high-grade ipsilateral OA affect our choice of fixation for that now extracapsular fracture?
It creates a real surgical dilemma. The standard protocol for an unstable trochanteric fracture is internal fixation, no question.
Right.
However, if that patient has grade 4 OA, we know their hip is already functionally compromised. It will likely become painful or require replacement in the short to medium term anyway. So some authors are now arguing that for unstable extracapsular fractures in the presence of severe ipsilateral OA, we should consider a primary prosthetic replacement, a total hip arthroplasty.
So you're suggesting replacing the joint and fixing the fracture at the same time.
Yes, effectively converting the unstable fixation challenge into a primary arthroplasty. You're anticipating that the internal fixation hardware is likely to fail, or more commonly, the patient will develop intolerable pain from their progressive arthritis, and that will necessitate a secondary, technically challenging revision procedure down the line.
A one-and-done approach.
Potentially. It remains an area of very active debate and research, but this predictive correlation between the K&L grade and the fracture pattern is the foundation for this whole evolving treatment discussion.
That exemplifies how foundational research is constantly refining our clinical decision-making. Let's pivot now to the leading edge of orthopedic innovation. We can start with small joint surgery, focusing on the distal radius fracture, or DRF, and how MIPO principles are being applied there.
The DRS is incredibly common, of course, and MIPO has delivered some crucial functional benefits in this specific area. Here, the advantage is explicitly anatomical.
And what's the key structure?
It's all about the preservation of the pronator quadratus muscle, the PQ.
Right. Conventional volar plating, using something like the modified Henry approach, often requires you to raise or even divide the PQ to get adequate exposure and place the plate correctly.
Right.
What's the functional cost of compromising the PQ?
The PQ isn't just a muscle for forearm pronation. It's a critical dynamic stabilizer of the distal radial malar, the DRUJ.
Okay.
When it's compromised, patients often experience a protracted recovery of their grip strength. They have reduced pronation force, and they can have persistent instability symptoms during complex movements. MIPO avoids this. By using a smaller, more distal incision, the plate can be tunneled proximally underneath the muscle, preserving the integrity and the insertion of the PQ.
And what measurable functional rewards were seen in the clinical case series that used MIPO for unstable distal radius fractures?
The results really underscore the benefit. The average incision size was very small, typically around 2.7 centimeters. They reported a perfect 100% union rate, which is excellent.
And functionally.
Critically, 62.5% of the cases achieved good to excellent outcomes based on the Mayo risk scores. The early preservation of grip strength and the reduced risk of long-term DRUJ symptoms are significant drivers of patient satisfaction and a faster return to work.
So again, respecting the anatomy is paramount.
MIPO demonstrates that in areas that are sensitive to muscle function, it's absolutely paramount.
This theme of avoiding disruption and perhaps avoiding permanent foreign material altogether naturally transitions us into material
A
science.
huge area of innovation right now.
Titanium is the workhorse of orthopedics. It's strong, it's biocompatible, but it presents two fundamental issues. Stress shielding, because its elastic modulus is so much higher than bone,
Right.
and the high rate of secondary surgery that's required for symptomatic hardware removal. Are we finally approaching a viable next-generation alternative?
We are seeing immense progress in bioresorbable materials, particularly magnesium alloys, which are designed to address exactly those shortcomings of permanent metal.
Talk a bit more about the stress shielding.
Titanium's stiffness is often 10 times higher than cortical bone. This leads to stress shielding, where the plate carries too much of the load and the bone underneath doesn't get the mechanical stimulus it needs, which can cause local bone loss. And as you said, removing symptomatic hardware is costly, it's invasive, and it carries its own set of risks.
So introduce us to the alloy WE43 and its theoretical advantages.
WE43 is a specific high-strength magnesium alloy. Its primary physiological advantage is that its elastic modulus is far, far closer to that of cortical bone.
So it shares the load better.
It shares the load more naturally. This significantly reduces the risk of stress shielding and encourages a more physiological bone remodeling process. And of course, the other key feature is that it degrades gradually in vivo, which should negate the need for any removal surgery.
That sounds like the perfect solution, but we know the path of resorbable materials has been fraught with challenges over the years. What is the fundamental complication during the degradation of these magnesium alloys, and what's being done to mitigate it?
The primary challenge, and it's an unavoidable one, is the formation of hydrogen gas as the magnesium corrodes in the aqueous, slightly acidic environment of the body.
Right.
The reaction releases gas that can accumulate locally and that can potentially cause transient swelling, pain, and inflammation. Early animal studies did indeed observe this effect. They noted the presence of localized hydrogen bubbles and an associated inflammatory response.
So is this accumulation of hydrogen gas a deal breaker for clinical use? How are researchers trying to control the degradation rate to make this material viable, especially in small, confined anatomical spaces like the wrist?
It's not a deal breaker, but it absolutely requires control. Researchers are employing quite sophisticated surface modifications to slow the corrosion rate right down.
Such as?
This often involves applying protective coatings, like fluoride layers or specialized polymer coatings, to the WE43 implant. These layers act as a temporary barrier, slowing the degradation process down to hopefully match the rate of bone healing.
It's a timing issue.
It's all about timing. If the plate degrades too quickly, you get mechanical failure. If it degrades too slowly, you risk prolonged hydrogen evolution, and you might need to remove it anyway, defeating the purpose.
And what about its strength?
In terms of mechanical performance, static biomechanical testing of WE43 miniplates in small bone applications has already shown non-inferiority to titanium plates in terms of peak force at failure.
But there's a caveat.
The caveat is that clinical acceptance really hinges on dynamic testing. We need to see how it performs under cyclical mechanical loading conditions that mimic patient movement. We need robust data demonstrating that the material can maintain sufficient load-bearing capacity for that critical 6 to 12-week period before consolidation, while simultaneously beginning its controlled resorption. That comprehensive dynamic data is the current hurdle we need to clear before widespread adoption.
So we're moving from a permanent fixture to a temporary, sophisticated scaffold, but the timing of its disappearance has to be engineered perfectly.
Precisely.
This focus on engineering and precision brings us to our final frontier, the digital revolution that's driving orthopedics forward. The small bone and joint market is projected to reach over $8.1 billion by 2031. How are 3D printing and AI moving the needle from generalized treatment to truly personalized patient care?
They are providing the precision tools that we need for true personalization. Starting with 3D printing, its greatest value really lies in tackling complexity.
In what way?
For severe bone loss, for revision surgeries, or for complex fractures where a standard off-the-shelf implant is a poor compromise, 3D printing allows us to fabricate custom, patient-specific implants. These are designed precisely from the patient's own preoperative CT scans.
What's the measurable clinical advantage of this custom, patient-specific approach?
In highly complex scenarios, particularly those revision surgeries, the benefits are significant. Custom, patient-specific implants have been documented to reduce complication rates by over 20% compared to using traditional stock implants.
Why is that?
The superior fit reduces instability, and the ability to customize the surface porosity enhances bone ingrowth. This leads to more reliable, long-term outcomes, especially in joint reconstruction.
And then we have AI.
Secondly, yes, the rapidly evolving field of AI-driven planning. Historically, surgeons relied on manual templating, tracing on film overlays, and just experience to choose an implant size and predict the alignment. Now, AI tools are leveraging machine learning and deep learning algorithms to analyze huge volumes of imaging data, CTs and MRIs, to generate highly accurate predictive models.
How does the AI actually execute this planning? What is it doing that manual templating can't?
The AI performs several functions at once. It accurately segments the anatomy, it identifies all the anatomical landmarks, and it can model the joint kinematics under a simulated load.
I see.
It can then factor in patient-specific parameters like predicted bone density distribution to suggest the optimal implant size and rotational alignment. It effectively minimizes the risk of a mechanical mismatch or impingement postoperatively. It reduces the reliance on guesswork and anatomical averaging.
Can you quantify the improvement in precision that this technology provides?
Yes. A critical finding in shoulder arthroplasty research demonstrated that AI-driven preoperative planning reduced the final alignment errors by nearly 30% compared to traditional methods.
And better alignment means better outcomes.
Better alignment in arthroplasty is directly linked to enhanced joint longevity, a reduced risk of dislocation, and ultimately a superior long-term range of motion for the patient. This isn't just an academic improvement, it's a direct enhancement of surgical quality.
So the trajectory of orthopedics seems clear. MIPO provides the biological advantage. New materials like W43 offer a biodegradable scaffold, and this digital suite 3D printing for custom hardware and AI for precise planning provides the ultimate roadmap for minimizing error.
It's becoming an integrated precision ecosystem.
We've covered a tremendous amount of ground today. To synthesize the major shifts, MIPO is now demonstrating superior biological outcomes, faster union, lower complication rates in the humerus, provided, of course, that rotational alignment risk is managed with precision.
A critical proviso.
We also clarified that in open tibial fractures, internal fixation offers measurable functional benefits for those lower-grade injuries, but external fixation absolutely remains vital for high-grade contamination and soft tissue loss.
And we gained a profound insight into the geriatric patient, discovering that advanced hip osteoarthritis possesses this powerful predictive capacity, driving fracture patterns away from that high-risk intracapsular zone and toward the extracapsular region.
Finally, the convergence of these MIPO techniques with bioresorbable materials like W43, coupled with the unmatched precision offered by 3D printing and AI-driven planning, really does promise an era of increasingly personalized and error-minimizing orthopedic care.
This shift signals that we must move away from standardized hardware and one-size-fits-all treatment protocols toward a model where every surgical plan is meticulously tailored based on both the injury pattern and the underlying biology and pathology of the patient.
If you found the insights from this deep dive valuable to your practice, we would greatly appreciate it if you could rate and share this deep dive.
Before we sign off, I'd like to leave you with a provocative thought that builds directly on our discussion of the proximal femur.
Please do.
Considering the strong and predictable correlation between high-grade hip osteoarthritis and an extracapsular fracture pattern, how should this predictive capacity inform the primary treatment algorithm, specifically, the choice between internal fixation and primary arthroplasty for unstable extracapsular fractures in the context of coexisting ipsilateral OA? Should we just fix the fracture, or should we preemptively address the underlying joint disease at the same time?
A question that demands some critical thinking about long-term patient mobility and hardware longevity. Thank you for expertly guiding us through this challenging evidence today.
It's been my pleasure.
And thank you for joining us on the deep dive. We look forward to diving deeper with you next time.